So for this lecture, we're going to examine some of the treatment options that exist for stroke, specifically ischemic stroke. There's learning objectives. So by now you know that stroke, at least in the context of ischemic stroke, is a reduction of blood flow in the brain, and then this can obviously result in a neurodeficit. And so depending on the size of the stroke or the infarct, you can get kind of profuse neurological damage. This would kind of be in contrast to what's termed mini strokes or TIAs, and that stands for transient ischemic attack. And these basically are little small vessel strokes that occur, and usually within 24 hours you can see some types of deficit. It's quickly becoming I think the current estimate is the 5th leading cause of death here in the United States. And so from a therapeutic or a management kind of goal, there's a few ideas in terms of how to kind of combat this. And so the first thing we want to do is reduce the ongoing injury. So obviously stop the infarct. We would like to decrease mortality. We want to prevent brain damage. And most importantly, we want to prevent another stroke. And so there's not really many drugs that we can use to physically treat the actual stroke that's occurring. Basically, there's two options. There's IV alteplase, which is typically given immediately. And this is a clot buster type drug, and I'll show you that mechanism in the next slide. And then, of course, our old friend aspirin. And that's best usually within 48 hours of the initial symptoms. So let's talk about alteplase. This is one of those kind of recombinant enzyme proteins. This is a serine protease that cleaves proteins, and this is the 2nd generation molecule. I didn't even include the grandparent streptokinase because nobody really uses that anymore. Streptokinase, as you can tell from its name, is an enzyme that was made by recombinant bacteria, and of course often elicited an immune response. And so we don't really use streptokinase anymore. Pretty much we've been using alteplase, and I think that's kind of a good place to start. This drug has a really short half-life, from a few minutes to maybe 30 minutes, depending on the vasculature circulation, and it's administered IV. And this drug has been shown to be very effective when given within 3 hours of the initial onset of the ischemic attack. And you basically have to confirm with imaging studies that there's no active bleed. And so if there's an active bleed, then that's a hemorrhagic stroke. Okay, this is what we're trying to deal with right here, is the more frequently encountered ischemic stroke. Okay, and so the latter generations of alteplase, now there's another kind of newer and improved retaplase, which has a longer half-life. Then the most current flavor is tenecteplase, which has a much higher affinity for the clot, and I'll show you that in the next slide. Of course, with that longer half-life comes more cost. And so the major side effect to any of these drugs, and they all end in ASE, is really just the systemic bleeding. And so you really kind of have to monitor the patient quite closely. And of course, if they just had a stroke, they're going to be in the hospital, of course. So these thrombolytic drugs, like alteplase, basically work the same way. So in the context of a stroke, a DVT, a pulmonary embolism, myocardial infarct, all of those are ischemic events, right? And they basically produce an environment where there's low oxygen perfusion. Okay, well, this kind of feeds in or activates this plasminogen cycle. And so plasminogen basically gets converted to plasmin, and then active plasmin converts fibrin into its inhibited or degraded form. And basically fibrin is the thing that basically preserves a clot. And so when you activate this pathway, as these fibrinolytics do, you actually produce fibrin degradation. And so this is basically central to restoring perfusion, because what you do is you dissolve the clot. Okay, and so alteplase and tenecteplase and all these other ones that I just mentioned are your classic kind of fibrinolytics. And so fibrin and then lytic, meaning buster. And so these are clot busters. And so the fibrin is kind of the thing that holds the clot together. And these alteplase type molecules have a very, very high affinity to these fibrin molecules, and they really just bust that clot open and restore perfusion. And that's really the main goal in actually treating acute stroke. Now, aspirin is also therapeutically relevant. It's really kind of the gold standard in what's termed secondary stroke prevention. Okay, so really just preventing another stroke from occurring. And by now, you guys all know how the mechanism of aspirin works. It's an irreversible acetylator of specifically COX-1 on the platelet, but also COX-2 at higher doses. From a therapeutic perspective or from a pathophysiological perspective, we're really talking about irreversible acetylation of the COX-1 enzyme that's specifically found on platelets. That's really the mechanism in terms of ischemic insults. And so low doses, typically in MI, we talked about very low doses at 81 milligrams. It seems that for the stroke patients, we're doubling it to 162 milligrams per day. And that really favors inhibition of much more COX-1 activity on the platelet than COX-2 activity. And we had talked about that in the previous case. And so secondary stroke, basically what we're trying to do is we're trying to prevent another stroke from occurring. And so really that basically translates to we're going to start properly treating the comorbid diseases that produce an increased risk for developing stroke. So hypertension, atherosclerosis, hyperlipidemia, uncontrolled atrial fibrillation, all these diseases really kind of exacerbate another stroke. Okay, and so that's kind of really the hallmark of stroke prevention. And so what do those treatment strategies look like? Well, this is kind of a review from the last few blocks. If the patient has atherosclerosis or high LDL, low HDL, we're looking at intense statin therapy. If they've got a hypercoagulated state, we're thinking more of the anticoagulants like warfarin. Patients that have atrial fibrillation would also be on warfarin as well. Hypertensive patients, we talked about ACE inhibitors, ARBs, beta blockers, and then patients that have basically platelets that are overly active, which kind of comes under the realm of hypercoagulated states, are best treated with aspirin and clopidogrel and some of these other drugs. And so basically, by way of treating the other disease, we can reduce the incidence or the recurrence of another stroke, okay, which is kind of central to the treatment strategy. So what we've really been talking about is ischemic stroke. Understand too that there's a hemorrhagic stroke, and so this is an ischemic stroke. Obviously, is due to a clot producing an infarct that basically renders the localized area to be less perfused. Here we're looking at a hemorrhagic stroke, which is the opposite. So this is an active bleed in the brain, and so the goal is to really stop the bleeding, and you can accomplish that with basically several drugs out there. Mannitol, which is an osmotic diuretic, as well as some of these anti-seizure medications, both of which we will talk about as kind of a main treatment strategy in another case, so I'll kind of reserve those two drugs. Understand when we talk about stroke, we're really talking about ischemic stroke, and kind of our go-to drug to really open up that clot is alteplase. Okay, so only really two main drugs, and then an introduction to another group of drugs for another less frequently encountered disease. Okay, so relatively straightforward lecture today. Thank you.